So next, we're really very happy to have, so I guess you're going first? Gilles going to go first, good. So Gilles Plourde, professor in the Faculty of Medicine at McGill in the anesthesia group. And Gilles and I actually go back a ways because I was looking up our 2006 paper, which was using brain imaging and anesthesia to look at auditory processing. And even way before that, you were quite involved in research on brain imaging with anesthesia. So we're very happy to have Gilles here. And also Christian Guay, who is working in Gilles' lab. And they, I think, the way we set up the order is very good because three of us gave a very nice introduction, some of the same questions that Drs. Plourde and Guay will be discussing today. So thank you guys for coming down.
Well, thank you very much, Robert, for the invitation to this very interesting event. I must apologize for my patchy appearance. It's a spring break, and the spring break vacation imposes difficulties for clinical staffing. So that's why I have this outfit, and I have a colleague who covers my room while I'm away. So first, I'll start by thanking the people who made this the actual work. Flavie was a clinical fellow, and she was, along with Shiva, who is an OR nurse, who was responsible for patient recruitment, EEG acquisition, and for some patients, clinical management of the anesthesia. Francis Arsenault did the preliminary analysis of the data. Funding for this was solely from departmental sources as our part of our fellowship program. And I would also like to thank, although he's not a formal collaborator, but I'd like to thank Jean Gottman, who gave advice on planning this project and whose wise counsels are always appreciated. My part will be to give you a brief overview of what general anesthesia is. And we'll start by saying how do you define a general anesthetic? And a general anesthetic is a drug. Its main characteristic is to produce immobility in response to noxious stimulus, basically skin incision, other than by simple paralysis of the muscle. And this goes back to the history of anesthesia. The first public demonstration that really initiated the era of anesthesia was in 1846 in Boston. And what amazed the people the most is that the patient did not move. They were not really concerned about consciousness. The patient did not move and did not scream. He seemed to tolerate the operation without any discomfort. Before then, surgeons operated on patients who were moving. And this was not a pleasant experience. This happened at the Massachusetts General Hospital, and you can actually, if you go to Boston, you can visit the Ether Dome where these historic events occurred. So you need a few more properties. These drugs also cause unconsciousness. It so happens that if you give a drug that produces immobility to skin incision, the patients will not respond to your commands and will appear to be unconscious. So sleep-like state and unresponsiveness to verbal commands, even forceful and repeated verbal commands. Of course, you need to add a few characteristics. The effect must be reversible. It goes without saying. And its administration must be compatible with maintenance of vital functions. Some drugs would do this, but would pose too much hardship on cardiovascular or respiratory function. There are two major classes of anesthetic drugs. There's the intravenous that are given by a vein, and the inhalation that are given via the lungs. Finally, there are other drugs that can cause unconsciousness, such as benzodiazepine, dexmedetomidine, opiates, but they're not anesthetics because you cannot give enough of these drugs to suppress movement in response to skin incision. No matter how much you give, the patients will still move in response to incision. In anesthesia, one of our main working tool is the concept of concentration. And if you set to 1 the concentration of a drug required for immobility, then most patients will become unconscious around 0.4 of that concentration. And you also get explicit amnesia, so suppression of explicit memory at a lower concentration of 0.1. Now, as I said, concentration effect relationships for us is a very basic and essential component. In this graph from Frank's review, you look here at 2 commonly used anesthetics, propofol, which we heard about, and sevoflurane. Propofol is an intravenous drug, sevoflurane is an inhalation drug. This is the fraction of unconscious patients, and the way we define unconsciousness is failure to respond to commands. And this is millimolar concentration, and you can appreciate the extreme steepness of these curves. It's much steeper than any biochemical agonist receptor interaction, at least 10-fold, and for both drugs. Now, these very sharp concentration curves ensure that this concept is a very useful tool clinically, given the precision with which we can predict just by concentration alone whether a patient is conscious or not. In the case of sevoflurane, we can actually measure in real time the concentration. In the case of intravenous agents such as propofol, there's no way to measure it directly, but we have tools to estimate fairly accurately with 10 to 15% error margin the actual concentration. So any EEG monitor that you want to use has to be extremely good because these concentration values are already an extremely good predictors of the level of consciousness of the patient. So why do we use EEG during anesthesia? Well, first, we can use EEG to measure the integrity of the brain or brain structures, but this is not very useful. It can be used to optimize dosing of anesthetic drugs or to detect the accidental regaining of consciousness during surgery. And for these 2 purposes, processed EEG is almost exclusively used, and by processed EEG, I mean it usually transforms into a single number. But it's not very popular in Canada because of concerns over the real usefulness. Another tool where we use EEG is the for pharmacodynamic modeling, and it goes with the concept of the concentration, is that we can give an infusion of a drug, in this case fentanyl, and look at the EEG effect of this drug, the slowing of the EEG, the spectral edge, and look at the concentration in the plasma. And by studying the delay between the concentration and the onset and the offset of the drug, we can make very accurate models that allow us to predict the actual concentration of the drug in the brain. And finally, and that's the most relevant for this talk, is how can we investigate mechanisms of general anesthesia? And I'm comforted by the idea that in the Science 125th anniversary, they considered that this was a worthwhile topic to study. I will skip this because I want to leave time for Christian, but the main point is that there's no unitary mechanism of action that can explain anesthetic drugs. For example, xenon, a noble gas, is a general anesthetic. These are halogenated hydrocarbons or ethers. There's no single molecular target, But GABA potentiation is by far the most common effect, and especially in the case of propofol, it's largely the dominant effect. So if we go back to EEG, in the 1950s, there was already interest in the EEG, and this is from the classic review of Clark and Posner that reviewed in 1973. And essentially, the changes are still, the sequence is still valid today. And here how they described. They said that the first changes induced is, in the EEG, is a 20 to 30 hertz waves, so beta activation. And that eventually it leads to some 5 to 12 hertz waves. And that loss of consciousness probably occurs as the initial fast response transits to the 512 oscillations. And then this was followed by large polymorphic waves. If you give more, you get to burst suppression and to isoelectricity. This applies to the vast majority of anesthetic agents. Essentially, fast rhythms at the beginning, some intermediate forms, and then slow waves. Despite more than 50 years of research, we still don't know exactly what happens precisely at the moment of loss of consciousness. Increase in beta, alpha dominance, as we've heard, especially frontal, onset of slow wave, decrease of gamma. And this is partly due to the fact that the method used to assess consciousness, response to comment, has poor time resolution. You find the exact moment within about 15 seconds, given the time to repeat the question and the delay of the patient to respond. And I'm going to let Christian describe how we found a way to have a more precise time of loss of consciousness.
Merci, Dr. Plourde. So in the spirit of today's and yesterday's workshop, this is going to be non-published data and experiments that we've been working on, and we're looking for input from a lot of people. I'm going to present our methods, some of our results, and what we're thinking in terms of physiological substrates that are leading to our results. So the goals of our study here is really to characterize the progression of the EEG as the patient moves into loss of consciousness. As Dr. Plourde mentioned, looking at that exact moment, we're trying to pin down what happens right when you lose consciousness and ultimately lead this back to biological mechanisms with the hope that we can derive physiologically principled neuromonitors instead of empirically derived ones. So first, operationalizing consciousness. This is something we always have to do before we study consciousness, and this is just one of the models to look at it, and it's relatively useful in anesthesia. Where at first you've got a sensory motor response to commands. As Dr. Plourde mentioned, this is what's mostly used in the operating room. We're asking a patient to open their eyes, we're asking them to squeeze their hands, etc. And when they stop doing that, we infer that they are no longer responsive and therefore have lost consciousness. However, as Dr. Owen has shown, and others also, you can go a little bit deeper. Even if a patient can't respond, they can still remain conscious, and you can look at locked-in syndrome, and the example of dreams, of course, provide an example where someone may be conscious without any connection to their environment. So what we're going to be talking about today is right at the top there, the sensory motor response. So what we used as a behavioral measure of consciousness was a patient's ability to hold an object. So the patient holds the object in the operating room as we anesthetize them, and when they drop the object, we use that as a timestamp on our EEG to look at what happens at that moment. As I said, this is contingent on us accepting that when they lose consciousness, they're going to drop the object, that those two occur at the same time. So that's one of our assumptions, which we can debate afterwards. So as Dr. Plourde mentioned, the main advantage of this is the temporal resolution, so we don't have to constantly keep asking questions, and we're not contaminating the EEG with any auditory potentials. So who are we selecting for this? We're selecting healthy patients that are coming for spine surgery or peripheral nerve surgery, so we're assuming that they have normal brains. no major comorbidities that would render them in danger for a slow infusion of propofol. Here's our protocol. So they come into the OR already set up with EEG, closed eyes the whole time. So we take 2 minutes of waking EEG, followed by baseline holding of the object again for 2 minutes. At that point, we start the propofol infusion, and that'll run until they drop the object. There's a fair amount of variability, as we heard before, in actually the time of onset of propofol effects. And so we had between 2 and 4 minutes, depending on who we were testing. After that, we gathered another minute of EEG in the anesthetized state. Here's a little bit of the technical stuff. I'm not going to go into detail with this because you are all experts. Suffice to say that we used a low-density referential EEG, and a lot of the time in the anesthesia literature, we're working in the frequency domain. That's where we get a really nice signal-to-noise ratio. Importantly, we're going to be looking at results aligned either to the infusion start of the propofol, or we'll also align them to the object drop, again, looking for what happens at that object drop. I should mention also change point analysis is one of the mathematical methods we use to try to look for inflection points in our data. It's looking at the cumulative sum of deviations from the mean. We took this from financial and environmental models. And so when you've got a peak from that cumulative sum, we infer that there's an inflection point in the data. And we'll see that in the next slides. So this is just an example of that change point analysis. And so you can see that these are the cumulative sums. It peaks right here. And in fact, if we look at the data, that's how we're going to say that you've got the change. OK, so here are results aligned with the propofol drop. Propofol infusion start. So time 0 is when we started propofol. And I aligned them here in decreasing frequency. And what we see is just about a little bit later than a minute after the onset of propofol infusion, we get multiple peaks, sequential peaks in alpha, sigma, and alpha bands. This is concurrent with a decrease in your high gamma and also low gamma, which is not shown here, and then an increase in the delta afterwards. So we see a relatively robust progression of the spectral powers going through these 3 peaks and then a rise in delta, which is well described before, as Dr. Plourde mentioned with the beta. So when we look at these all in one, it's reminiscent of some work that's been done in other sciences like radioactive decay and chemical reactions, where you are starting an initial state, going through an intermediate state, and ultimately reaching a final state. And this has been applied to neural transition points in the sleep literature by Merica down here. And this is our data here. And so all this is in line, again, I'm trying to tie this down to physiology, where you could have a oscillation of your thalamocortical network in the gamma when you're waking, pass through these different bands as intermediate states, and ultimately reach the delta oscillation. Again, this is in line with Steriad's work on the different oscillation states of the thalamocortical network, where you start in tonic firing when you're awake, which gives you the gamma band, and ultimately when you're achieve sleep or an anesthetized state, it's a burst firing mode, which gives you the delta. This is just, I'm going to skip this one. It's essentially looking again at biological mechanisms of what those intermediate states would be, but we can talk more about this later. Okay, so now let's align everything. Time 0 is going to be at the object drop. What we're looking for here is what's happening right before the drop. And what we're seeing is the green lines are 3 standard deviations away from the baseline. Whenever you get red little dots, that's when you're outside of that range. And the blue dash is the change point analysis. So if we look at all this, again, there's a progression, but we're not getting anything really at time 0. And so what we did is we created a relative delta value, slow wave activity. So the relative delta power over time. And what we find is that it gets pretty close. It's in the seconds leading up to the object drop. We see that there's an inflection point in the relative delta power in our EEG montage. And it's a really good predictor for that object drop. So I'm going to talk a little bit about the slow wave activity, where this came from. It was work by Warnaby's group at Oxford, and they used a very slow infusion of propofol. So we're inducing an anesthetized state in 2 to 4 minutes. They did it over 45 minutes. Again, they're using verbal cues, and so they're this is loss of behavioral response here, LOBR. That's in response to behavioral cues. And as you see, that happens relatively early on before the inflection. Again, that may be due to the time resolution, to the slow infusion, etc. But what they noted is that they had concurrent fMRI, and they still have a lot of activation before they ultimately reach what they call a slow wave activity saturation. And this is essentially the point where you've had saturation of that transition from a tonic firing to burst firing thalamocortical system. And at this point, again, you note the fMRI, you're really only getting default mode activation. And so then the question, what they propose, is that in here, between the loss of the behavioral response and the slow wave saturation, you have a state of connected consciousness, but unresponsive. So this is, again, analogous a little bit to what we've been talking about over and over the past day, where you can have patients who cannot respond to your commands, who cannot interact with their environment, but are still connected. They can still get sensory input, and they can still be aware. And so exploring in this by using different behavioral paradigms, I think that we can glean a lot of information about the process of actually shutting down the brain and ultimately reviving it afterwards. So I'm gonna wrap it up here because I'd like to leave some time for questions. But before I do that, I'd like to really invite everyone, wherever you're working, to seek out your Department of Anesthesia with the thought that every single anesthetic is in fact an experiment on consciousness. So you have patients going into coma and out of coma every single day in your operating rooms. And if you have strong behavioral paradigms, you can really explore a lot about how those paradigms are affected when you go in and out of consciousness, and ultimately hope to apply this to the basic sciences, but also clinical care. Thank you.
Thank you, Christian and Gilles.
That's really interesting. I had 2 questions, and I don't really meet that many card-carrying anesthesiologists, so this is a perfect opportunity. So the first one was, so you said it's quite standardized. We have got accurate means, you said, of measuring concentrations. And did you mean blood concentrations? Because that is an invasive procedure which you don't do every time. So what is the other way with which you measure concentrations at an individual level rather than based on, let's say, the Marsh model or something like that?
Well, for inhaled agents, we can measure it with monitors in expired air. And if we let sufficient time for equilibration, typically 10-15 minutes, the partial pressure in expired air is the same as in the brain. So we measure actually the brain, the same concentration as the brain. For propofol, we can measure it in arterial blood, but we don't do this routinely for clinical practice, but it can be done. And with the models, we can estimate the concentration in the brain. And the protocols that you've used, probably the Marsh model, incorporates, gives you the effect site concentration, so factors in the delays for equilibration to ensure that the concentration in the brain is stable.
Okay, if I have one more question. It's this object drop. That's interesting. And I just want to understand from your perspective what you see the object drop as meaning, and is that a standardized concept in the anesthesia world?
It's not widely used. We did before a validation, and the vast majority of patients, when they drop the object, if you immediately ask them to open their eyes, they won't. There are a few patients, and usually they tend to get agitated before, and they start wiggling around and moving the weight. Those sometimes will drop the object before falling asleep. But the vast majority, and all those in the study, when they drop the object, they look unconscious. We did not specifically, in this study, test immediate response not to disturb them. But in a preliminary pilot study, we found that when they drop the object, 90% or more of the patients are unconscious, and those who are not, we usually see some aberrant behavior during the object holding.
Yeah, also, just a quick point on there too. It's a great question because in fact there is no standardization in the measuring of consciousness in the operating room. There are no standards.
And that brings me also to another point, is that the Varnaby study, they use the patient's name via earphones, but we've shown that if you yell at the patient by the bedside, it's more effective than either instructions to press a button if you hear a different sound, or even their own names digitized. Often we've had patients who during natural sleep would not, they just fell asleep during the baseline because they didn't sleep the night before, but that's another story. And no response, you yell at them and they respond. So the difference in stimulus intensity may explain some differences in results.
Fascinating work. Sure. Thank you for it's really fascinating work. I wondered if the change in the rate of delta from anesthesia delivery to the dropping of the weight is indicative of how quickly the patient returns to consciousness. Are you able to ask that?
This is an interesting question, but we haven't looked at that yet because with these studies are done with patients, and the return of consciousness is compounded because they have the surgery in between, then there's pain, opioids, and it doesn't make for a clean study design. But this is certainly something that would be of interest if we were starting again to test volunteers. But I need colleagues to help me, and we're short.
In view of the popularity of the bispectral index, did you, besides spectral characteristics, did you look at some of the higher order polyspectrum?
No. But that's something that we'd like to explore, the higher order, especially since the higher order spectra are the part that, for the bispectral index composition, are they compose the higher part of the curve, whereas with the transition between deep sedation, moderate sedation, deep sedation, or unconsciousness. But no, we have not yet done that. We haven't looked, we're trying to look at scalp distribution as well, but it's not yet done.
More questions?
I'm just curious if you took any muscle activity measures, so EMG, and how you actually time locked the EEG activity to the object drop.
Oh, that would be something interesting. Yeah, maybe we can talk about that after. So, Christian will talk. Yes.
Good. Thank you very much.
Thank you.